instead of experiencing dramatic relief, they will experience dramatic worsening. Because you're closing that interscalene space, you're squishing the costoclavicular space, and you're putting some stress on that pec minor. So you're really hitting all the points. And they will not like this maneuver. So that would be the only difference between Bacodi and reverse Bacodi. Two differences. Two different indications. Bacodi is for radiculopathy and they get relief. Reverse Bacodi is for TOS and they feel worse. So it's a quick way to differentiate. It's not always that simple, but if it is that simple, it really gives you some good answers. Doesn't tell you whether it is vascular or neurologic, although it's probably going to be neurologic because if it happens instantly, a vascular change won't occur that quickly. That basically means when you're doing this, the reverse Bacodi, and they go, doc, I can't hold that. You're doing what they say in Georgia, you're pinching the nerve. And they don't like that position, so they'll avoid it. Reverse Bacodi maneuver. Same thing as Bacodi, but it just gets worse. Next, Roux test. It's pretty hilarious. A lot of docs think their test is the best test since sliced bread. We talked a little bit about Sperling and how he went through all those machinations. Roux is not lacking in ego. He basically said the same thing about his test, although the data do not bear this out. And it is very, very simple. It is for a vascular TOS, and arms abducted to 90, elbows at 90, and opening and closing the hands quickly for 3 minutes. I've never seen a 3 minute, a true vascular TOS last 3 minutes. Think of it this way. The analog is like claudication in the calf due to peripheral arterial disease. Are you familiar with that yet? Some of you all? Okay, well, how about angina for cardiac abnormalities? There's a narrowing of blood supply to the heart. Patient can get along as long as the demand is low, but when they increase the demand, the cardiac muscle requires a lot of oxygen. So increased demand causes the cardiac muscle, the myocardium, to scream and send all kinds of signals to the central nervous system, and you will experience pain. This is essentially angina of the arm muscles on the affected side, usually unilaterally, and all you're doing is creating a demand. You're exacerbating it positionally, because remember, up to 70%, 60 to 69% of people normally experience this, pulse obliteration with arms above the head, but when you add muscle demand, you really, really put the heat on those muscles. So if there is a paucity of blood getting to those muscles, 3 minutes isn't going to happen. Mm-hmm. And what will happen? Typically, the patient will, this is the classic one, according to the book, this is book learning versus real life, so I'll give you the book learning. The book learning part, they'll do this, they'll go almost 3 minutes, then their arm will drop to their side. Between me and you. But in real life, what will happen is they'll get about 30 seconds, 45 seconds in, and their affected side will start to ache, and then it'll start to droop. Then they'll look at it like, what's happening to me? Then they'll do this to try to say, well, no, doc, it's normal. They'll hitch their shoulder up. This is
Bless
very,
you.
very common, bless you, very common thing. So in real life, it isn't like they're fine and then all of a sudden it drops. I've never seen that. I've heard of little green men. I've just never seen one. But they'll do this, demand becomes increased, arm starts to ache, then it starts to give out. They look at it like this is not acceptable, then they cheat, and then you got your answer. So that is a Roux test. 3 minutes, 90 and 90, open and close, fast, rapidly. How rapidly? Rapidly. looks like this. This is out of Malanga, a really good textbook. And it's just, it's also known as the EAST test, Elevated Arm Stress Test. I added that because I've seen it this way in the literature. There's a movement in the current orthopedic and sports medicine literature to try to get away from these eponymic tests, like Brudzinski's and Fagerstein's and Koenig's. It doesn't help you to know what it is. Straight leg raise is pretty obvious, right? Well leg raise is pretty obvious, but Fagerstein, AKA well leg raise, is not. Bechtereau's seated straight leg raise is not obvious. So RUSE is being called now the Elevated Arm Stress Test, because that's just what it is. So I like to have that on my exams because I want you to see it both ways. You know, RUSE, of course, said his was the most reliable of all. You know? So funny. No data support it, but got it in the literature. All right, Tinel sign. Remember, Tinel is tapping on an angry nerve, irritated, inflamed nerve. The idea being that when you tap on that nerve, you facilitate it more, and distal to the point that you're tapping, the patient will typically feel paresthesia, tingling. Paresthesia is just fancy pants words for his medical speak for tingling. Not pain, or very rarely pain. It's typically tingling. And the classic place that is used is the carpal tunnel. But you can use it for the median nerve, the ulnar nerve, the posterior tibial nerve for tarsal tunnel syndrome. And only in theory, according to Gillet, or Gillet's cluster, for TOS. Dr. Gillet maintains that if you hit in the supraclavicular area, about midway, mid-clavicular, you will hit over that brachial plexus where it tends to get pinched, and it will irritate it distally, causing tingling. Some sources say supra and infraclavicular area, but let's disabuse you of that because there's a lot of stuff between your skin and the brachial plexus. You're going to have to really wail away. But Gillet included that in there because that's the only test in Gillet's cluster for TOS that has anything to do with neurogenic. 95% of the problems. All of the rest of them are vascular. You need to know about it because you could encounter it. So you're just tapping, using your two fingers as a pleximeter. Really doesn't matter what you use. You could use a reflex hammer, your fingers. Some people even use the side of their stethoscope. Please don't let me catch you doing that because that's a bad look. But use your fingers, just tap. Because you can feel where you're tapping. These are the plexors. These are the pleximeters, remember, for like lung percussion.
Mm-hmm.
Liver margin. What's the bubble in the tummy called?
Gas.
M.
Oh.
Magenblase.
What?
Magenblase. You should hear resonance over that gastric air bubble.
Haven't learned that
You
one.
ever heard that before?
Nope.
Well, now you have. So, Magenblase. Some even say Magenblase. G. Seen it both ways. That's not what, this is not that class. Gastric air bubble. You know about fremitus, tactile fremitus?
Mhm.
Okay, good. So paresthesias, and distal to the point of the Tinel percussion. Now the right test, this is where Gillet's test, it's only a little over 20 years old, goes wrong. That's old news. He separates out the right test from the hyperabduction test. Now the right test is AKA the hyperabduction test. So I teach it to you the current way. And I've I've never seen that. I've never seen it separated out on part four. So here's the thing. The right test is nothing more than essentially an Addison test without turning the head. It's a passive test. Palpate the radial pulse, and then you slowly abduct the arm through 180 degrees, and you note where you find obliteration of the pulse. Then you compare it to the other side. Now, I remember the right test. It may seem silly, but it works for me. The right test, the Wright brothers flew, so it's like you're flying. That's how I remember it. Flying, you're making them fly, right? Come up with your own mnemonic if you have a better one. If you do, let me know. I might ask you to steal it. So we're going to practice this because it is a little bit, it requires a bit of focus. The most common mistake is you are both, you're medical students, so you want to help each other. And so instead of letting your partner lift your arm passively, you want to help. Do not do that. They have to learn to lift the arm. Here is one where I'm going to suggest that unlike Dr. Evans here, he has his hand over, may I? He has his hand over the arm like this, and that's all well and good, but when you want to lift that arm, see, he's so nice, he's already helping me. But if I want to lift his arm, it's going to happen. Just tell the patient, oh, I can lift your arm. Or if it's a big guy, you can say, well, wow, I can barely lift your arm, make him feel good about himself, you know. But it's a passive test. Here's how I'm going to suggest you do it. You're going to reach this way and palpate, because now it's a whole lot easier to palpate that radial artery up to 180. This way, I would be surprised if you lift an arm and it doesn't slip through your fingers as you do so. And that's, you don't want to, it's kind of like when you're taking a blood pressure and you forget to put your stethoscope in your ears the first few times, or put them in backwards. It's normal to learn that way, but you don't want to do that. So do it the easy way. Do it like this. Much easier. I can feel his pulse beautifully. Just make sure in part four you don't make the common mistake of doing this, because it's easy to get, turned around. Happened in my semester 7 class a couple labs ago. Just make sure you only go to one artery for these TOS tests. It's always the radial artery. So let's practice that. Just get it. You don't need to do both sides. Let's assume you can do one.